Okay, we're going to move on to where we were talking about ROGAM. And ROGAM, and I also mentioned Rofalac, and that's RHOPHYLAC. They're both immunoglobulins. And Rofalac is given IM or IV. ROGAM is always just IM. So what does it do? Yeah, being an immunoglobulin, it prevents the production of the anti-RH antibodies in the Rh negative woman who have been exposed to Rh positive blood by simply suppressing the immune reaction of the Rh negative woman to the antigen in the Rh positive blood. So it prevents the antibody response, which we know is a normal response because it looks at it as an invading organism. And it's not, it's just the baby's blood. But the body doesn't know that. And so that's why we use these immunoglobulins, is that they're going to go in and suppress that immune system. And in doing that, it would prevent the hemolytic disease of the newborn. They use for both male and females who are Rh negative but exposed to Rh positive blood, or for immune thrombocytopenia purpura, also known as ITP. T as in Tom, P as in Paul. Indication for pregnancy related, again, administered to Rh negative women who have been exposed to Rh positive blood by either delivering an Rh positive infant, aborting an Rh positive fetus, undergoing chorionic villus sampling, any amniocentesis, or intra-abdominal trauma if they're in an accident or something like that, and they come in bleeding, and we don't know. We just know that mom's negative. We're going to go ahead and give her ROGAM. Must be given at 28 weeks of pregnancy. That's why they draw them in the very beginning to find out if they are. And state law here, 28 weeks of pregnancy and within 72 hours of delivery of an Rh positive infant. So again, when you're going to give ROGAM, we have to make sure that we do have an Rh negative mother and an Rh positive baby. Because if we have the Rh negative mom and we have an Rh negative baby, there's no problem. They don't need ROGAM. And there are women that have, 4 or 5 kids. A couple of them are Rh negative, the rest of them are Rh positive. So we have to make sure we check that. Because again, if the baby and the mom are the same, we don't need it. There hasn't been an antibody. There hasn't been an immune response so that we have a problem with the antibody antigens. So nursing implications for this, we're going to type an antibody screen of the mother's blood, and cord blood type of the newborn must be performed. Believe it or not, we used to do all the newborns' blood types, and anymore they just don't. It's unless there's a need for it. The parents can do it if they want to, but the cost, they don't want to do it because of the cost. If the fetal blood type after termination of a pregnancy is uncertain, the medication should be administered, because sometimes we don't know, depending on when they had the miscarriage. If they come in bleeding and they end up doing a D&C, they're not going to know. And if it's undetermined, again, if mom's Rh negative, we're going to give her the ROGAM. It's not going to hurt her at all. Okay, and here is our problem baby that has had, they refer to it also as fetal hydrops, but here's our erythroblastosis fetalis, hemolytic disease of the newborn, disabling or fatal blood disorders. When the child's born, signs may include an enlarged liver or spleen because of all the red cells being made as a form of compensation from the baby's heart, because their red cells are getting killed. And hence we have a problem. But the heart is, it's compensating at such a rapid rate that we've got a lot of those erythroblasts, or the baby red blood cells, and they don't carry oxygen. They're too young. They're not mature enough to. So, and here I'm just going to reiterate it again. The mother's red blood cells cross the placenta and destroy the fetal erythrocytes if the Rh negative mom has antibodies against the Rh positive blood. Infant becomes deficient in red blood cells, which are needed to transport oxygen to fetal tissue. As fetal red blood cells are destroyed, Fetal bilirubin levels go sky high. We've got kernicterus or encephalopathy. Hemolytic process results in rapid production of those baby blasts, the erythroblasts, immature red blood cells, which cannot carry oxygen. The syndrome is referred to as erythroblastosis fetalis. Basically, this is saying that there's a blast of red cells and their babies. And it can result in congestive heart failure of the infant. Okay. Let's see, what did I say? Yeah. All right, now we're going to move on to gestational diabetes. So gestational diabetes is impaired tolerance to glucose with the first onset or recognition during pregnancy, because it's only they're only diabetic because they're pregnant or it happened during pregnancy. The ideal blood glucose level, we know, needs to fall anywhere between 60 and 120 milligrams per DL. Symptoms of diabetes may appear a few weeks following delivery. However, approximately 50% of women will develop diabetes mellitus within 5 years of delivery. So I'm going to say that again. The symptoms of the diabetes may disappear a few weeks following the delivery, and sometimes it's right away. However, approximately 50% of women will develop diabetes mellitus within 5 years. So these people need to know that when they're doing this exercise and they're changing their diet and they're learning all about it, that it really needs to become, I would say, a lifetime habits for them because of what diabetes can do to our circulatory system, which is all the blood-filled organs. Gestational diabetes can lead to spontaneous abortion, infections of urinary tract and vaginal tract, which are related to increased glucose in the urine and decreased resistance because of altered carbohydrate metabolism. And we know that that's the mainstay of the disease. They can have hydramnios, which is a lot of fluid, and that also causes overdistension of the uterus. So they have, because of that, a lot of fluid. They have premature ruptured membranes, which leads to preterm labor, and it can lead to hemorrhage because we've got this giant uterus that's not clamping down. Ketoacidosis from diabetogenic effect of pregnancy, and all that means is the diabetogenic effect means increased insulin resistance. Untreated hyperglycemia or inappropriate insulin dosing. Hypoglycemia, which is caused by overdosing insulin, skipped meals or late meals, or increased exercise. And hyperglycemia can also cause excessive fetal growth, macrosomia, and it also leads to all these infections because of the increased sugar in the blood. Okay, let's talk about HPL here. And this is human placental lactogen. And it's another one from the placenta that helps keep the insulin away. It is diabetogenic. It doesn't like insulin. It doesn't allow insulin to work. And so because of that, we have insulin resistance. And with insulin resistance, we're going to have an elevated blood sugar. And that's going to lead to the pancreas cannot respond to this increased glucose level. Now, in a lot of pregnant women, the pancreas does just fine. But people that have gestational diabetes, it doesn't. The pancreas is very tired and it's having trouble responding to all this glucose, this increased glucose. And it's having a hard time. So excess glucose moves across the placenta to the fetus, and we have fetal insulin production. So now the fetus is producing a lot of insulin. And we know insulin is a powerful growth hormone. That's one of the reasons why the babies are huge. And we've got very, very large infants. Most of them are way over 1,000 grams. At which insulin resistance, and here we're going to pancreas can't respond. What am I looking at here? Oh, glucose. Glucose cannot enter the cells. We've got cellular dehydration happening. We've got fat and protein metabolism is being torn down because there's no glucose to help us. We've got, again, glucose cannot enter the cells because of insulin resistance. So we've got glucosuria, it's going out into the urine. We've got ketonuria. We've got, again, fat and protein metabolism, and fetal insulin production goes higher and higher and higher. And because the baby his pancreas is now saying, what's happening? And so we've got fetal polyuria, which we know that's a sign of diabetes. And we've got macrosomia, large baby, because of the insulin or the glucose not going into the cells, it's going into the blood, going right to the baby. And polyhydramnios, which is a lot of fluid. And because of that, because of this ton of fluid in the uterus, we've got premature rupture of membranes, and that's what that is, and preterm labor, which is sometimes a very difficult labor if we've got a very large child with a ton of amniotic fluid in there. Delivery of the baby used to having a lot of glucose on board. Their body is used to producing a ton of insulin. So the glucose input ceases, it just stops. But the fetus is used to producing all of this insulin, and so it continues just because that's what it's been doing. And so we've got a hypoglycemic infant. And, oh, you know what? I'm going to keep going. It's almost done. So for nursing assessments, we need to know the signs and symptoms of hypoglycemia, which is nervousness, headache, shaking, very shaky, irritability, weakness, hunger, sometimes blurred vision, very clammy skin, like they're going to faint. They can have shallow respirations and a rapid pulse, tingling of the mouth and extremities, personality change with the irritability for sure. Hyperglycemia, they're very thirsty, they're very hungry, they have that polyuria, polyphagia, and then polydipsia, nausea and vomiting a lot of times with hyperglycemia, and people think it's the flu. And so they give them sugary drinks and they're driving the sugar higher. So nausea and vomiting, abdominal pain, and they can have that acetone or very fruity breath. Tons of client education needs to go on about diet, exercise, and administration of insulin as prescribed. Client instruction on self-administration of insulin. And you know what? I am going to do one more tape. It'll be short, I promise. I'll be right back.